Good afternoon, everyone. I thank APOS and Dr. Gopal Raju sir for giving this opportunity. I'll be talking on ICL workup and case selection. I don't have any financial commitments to disclose. Ideally, refractive surgery is the one which should give best unaided visual acuity, photopic and scotopic visual acuity without any structural alteration, no, without loss of contrast, without glare and halos, without any adverse effects, and it has to be reversible. And we have multiple options of refractive surgeries like LASIK, surface ablation, ICL implantation, and clear lens extraction with multifocal IOL implantation, and a combination of all these things. And a refractive surgeon has to be aware of the every perspective of the refractive surgery, various surgeries, and we need to give an option of we need to select the best possible solution for a given case. ICN can be given as a primary procedure in all these indications, and there are multiple contraindications. Coming to a case, a male 20 years old with a moderate degree of myopia with astigmatism, with op scan shows right and left both pretty thin corneas. The best solution would be in this case is ICL. We have options, imported and Indian lenses. We have ICL is imported lens is made up of polymer, which is a copolymer of 99% HEMA and 1% porcine collagen, which is highly biocompatible. This material is very transparent and low reflectivity, so it is very flexible and latable, so that high degree of corrections are possible, and it can be implanted through very small incisions. This lens is being manufactured by Star. It's available in 4 sizes. It gives, this is the best lens which can give very wide optic zone and wide degree of corrections for myopia, hyperopia, with and without cinders are possible. And we need to know the load. This one is the correct orientation. For the correct orientation, they have given the marks on the foot place. For ICL, it is the leading right and trailing left. We need to remember that one. And this is the technique of Icl loading. In the first, prime the cartridge with the BSS and then HPMC. Then we need to take out the ICL with soft tip plunger, and we need to keep that one in the cartridge, and just rotatory movement of the soft tip plunger, we need to place the ICL into the cartridge, and with the weak forces we can catch hold of the ICL at the haptic optic junction, and we need to pull the cartridge over the lens, and then again the plunger has to be placed into the injector, and the cartridge is fixed to the injector, and we should not take much time. It should be implanted within 1 minute. The ICL placement, we need to check the ICL position. This is the ICL implantation technique. First, we need to make a side port and fill the chamber with viscoelastic. We should not overfill the anterior chamber. The threads of viscoelastic should be visible like this. And now the main port incision is being made, and the ICL is being implanted. We need to see the, as long as cartridge in our control, we can rotate the lens and properly orient the lens. We need to check for the orientation marks. These on the right side, we can see the orientation marks. So lens is in the is correct in correct orientation. First footplate is being tucked behind the iris, and then third, and then the fourth. And we have chosen a little longer lens, so that is the reason we have tried to place the try to rotate the ICL vertically. Now the viscoelastic is being removed. A rinse of aqua port, which is the central hole, aids in removal of the viscoelastic from behind the IOL. We need to take plenty of time to wash out all the viscoelastic from the anterior chamber, so that there won't be any postoperative pressure hike. Then wounds need to be hydrated like this. Other options are Indian phakic IOLs. They are from Appaswamy, Care Group, and Biotech. All these lenses are made up of hydrophilic acrylic. They look like this. Orientation marks are for Indian upper lens. It is like ICL only. It's reverse in the case of IPACL and Icl. And upper lens have a 4 holes at the margin of the optic. IPCL have 4 holes in the optic junction. In addition to that one, it has 3 holes. Biotech have only one center hole. Upper lens is thick, IPCL is thin, Icl is moderately thick, and upper lens is having small width, small optical zone. IPCL is having good width, good optical zone, and Icl lens is moderate width with good optic zone. And we can see there are various sizes are available. Customizable options also there in the case of upper lens as well as Care Group lens, and a wide range of corrections are also possible. But Icl lens, there are only 4 sizes available, and wide range of corrections are possible. This is the technique of implantation of biotech Icl lens. Chamber is filled with elastic, viscoelastic. Then ICL is placed so that convex surface should place upwards, and we need to check the alignment marks. It's left should be the leading here. Lens is being injected gently. It's a very easy lens to implant, biotech lens, when compared with any other lens. Then the foot plates are being tucked behind the iris. This actually is a toric lens. You can see the marks on the toric marks on the lens. Foot plates are being stuck. Lens is in the position. Then viscoelastic washout can be done. This is the upper lens. You can see the lens is smaller in size, but it is small with small optic zone with holes at the edge of the periphery. See, convex surface should face upwards. This is how we need to place the lens in the cartridge, and we need to implant the lens, and viscoelastic need to be washed out thoroughly. Upper suggests that we need to do YAG PI or surgical PI in these cases. Coming to sorry, there is some problem with the video. Coming to IPCL, the lens is very thick. Side ports are made, and viscoelastic is injected. You can see feel the lens. It's very thin. We need to orient the orientation holes properly before injecting, and this how it's being injected. We need to check the orientation. You need to make sure that these holes should be covered by the upper eyelid, and we need to tuck the foot plates behind the iris. Because these holes are larger, we need to we need to be very careful that we should not touch the crystalline lens. A comprehensive thorough comprehensive examination need to be done in all these cases for evaluation. A proper refraction is a mandatory. We need to take care of the retina as well. Otherwise, they will blame the surgeon once anything happens. Then we need to do all these investigation: keratometry, anterior chamber depth, pachymetry, white to white, IOP, gonioscopy, and specular count. Upscan gives good white to white when compared with other instruments, and anyway gold standard is digital caliper. White to white measurement need to be done in the operation theater under the microscope. We need to measure accurately, and again checked with the metal ruler. And we are using white to white as a surrogate for sulcus to sulcus. There are instruments like UBM and anterior segment OCT, but they are not standardized yet. So as of now, we need to depend on white to white alone. And anterior chamber measurement, all the instruments give good, but with the A scan and some other instruments, we need to we need to deduct central corneal thickness for anterior chamber depth. So all the missions are dependable for keratometry, and we need to have a habit of seeing the specular reflection. In any doubt, we need to do the specular count. These are the minimum endothelial density required for implantation of any intraocular procedure. We need to calculate these lenses using this software, APOS calculation software with provided by STAR, and we can choose the lens by calculating them. Otherwise, they will also help. This is the final printout look like. The chosen lens is given, and we need to understand about the vault. Vaulting is a central distance between the anterior surface of the cristal lens and posterior surface of the ICL. And ideally, it should have a half thickness, corneal thickness to 1.5 corneal thickness. That should be the ideal vault. If it is a low vault, it can give rise to cataract. A high vault, it can give rise to angle closure glaucoma. This is how the high vault look like, and this how low vault look like. And high power with laser vision correction, the vision would be like this, and ICL vision would be like this. So there are growing indication for ICL. There are nowadays most of the people are implanting the ICL because of less instruments are needed for ICL, and these also not without any risks. There are chance of infection in 0.1% cases, chance of cataract in less than 1% cases. So to conclude, right surgical procedure in refractive surgery is very important, especially when these phakic IOLs are available. So our goal is to give a not only 6x6 vision, but also a vision with 6 by happy. Thank you for your kind attention.
Thank you, Ramesh. That was an excellent presentation and covering all the basic aspects to the advanced aspects of the ICL at a given time. Before